may be limited as early surgery is beneficial in promoting mobilization and rehabilitation. Risk assessment is important to detect high-risk patients so that special care can be given to this kind of group. The choice of anesthesia depends on the patient's condition, nature of surgery, and anesthesiologist's experience. Most important, the technique is tailored to patient's condition and cardiorespiratory reason. Care must be taken intraoperatively to ensure a good recovery. Post-operative care is crucial as patients tend to have residual effect of anesthesia drugs. With that, I end my presentation. Thank you for your kind attention.
Thank you very much, Dr. Mariam. So we will be having a 15 minutes Q&A session later on at the end of the three lectures where three of our speakers will be on stage. So just a kind reminder for all our delegates to ensure either the silent
Mariam,
mode.
pakai your laptop ke?
Right, it is my
Laptop dia.
pleasure to introduce
Oh, okay. Ya, ya.
CEO Craig.
Tak kira otak. Ya, ya, tahu.
University of Malaysia and
Ada USB. Oh. Tak apa. Ini apa ya? Pointer. Oh, pointer.
we have interest in anesthesiology and here for the elderly population as shown by this anesthesia and intensive care, focusing on the special elderly population. So we Dr. Abdul Jabbar will be presenting on what's new in anesthesia for the elderly. With that, I welcome Dr. Abdul Jabbar.
All right. Thank you. Assalamualaikum and good morning to everyone. I hope I have already completed my PhD, right? Because I'm still doing it. But I have been doing and I'm doing many research in elderly population. So I have one research grant for it, and then we are doing multi-center study for elderly population. This is in regard to geriatric population in the ICU. So we'll be doing more on the anesthesia later part. Okay. So to start with, I'm from University of Malaysia Sabah, so the Faculty of Medicine. So you all already reached. Correct. So you already reached the Borneo Island. So from there, you can take another 1 hour flight to Sabah, Kota Kinabalu, and then you will reach at my place. All right. So the talk of anesthesia in elderly, what's new is actually the topic is very wide and have a lot of contents. So, but I will only given 15 minutes to deliver the talk. Okay. So what I did was I already recorded my talk online and then I already uploaded to YouTube. So you can scan the QR code and don't forget to like and subscribe because I only have 222 subscribers. I need to reach 1,000 subscribers. So I hope all the delegates can follow me. All right. So I posted a lot of anesthesia and critical care lectures inside there. So I recorded the talk 45 minutes last night. Okay, and I've already removed more than half of my slides. Okay, so it's like a summary, correct? You can say. So as you all know, all of us will be old. All right. So 25% of the world population will be old. In many countries, in even in Asia like Japan and so on, even in Korea, so the aging population is already a significant part of the society. Okay, but we always say age is just a number, isn't it? It's just a number, but the number is really high one. Okay, so aging is one thing. It's a certainty in life. It's confirmed we will be aging. We won't be reverse like that movie. That one movie reverse. Benjamin Button. Okay, so the age cutoff. So when I start to do my PhD, so the long discussion was what is the cutoff for aging? Some people say already 45. Oh, I feel old already. 50, I feel old already. Okay, so but if you look at the definition in the research and also from the governing body, WHO said 65 years old. United Nations said 60 years old. Okay, so this the two cutoff that usually being used to describe aging. I mean elderly population, older people. Okay, so for geriatric anesthesiology, I divided the knowledge into two parts. One is timeless, and another one is update. Many of you use Windows, right? This is a Windows update logo. So I know everyone hate it. Me too. So certain aspects are timeless knowledge, and Dr. Mariam have already explained some of it. And other aspects require more updates as research findings emerges. So physiological changes in elderly will happen, and many of you, including me, already starting to feel the changes. Okay, for me, it's mostly in the ankle. Okay, so then there will be cognitive decline, decreased efficiency of the heart, respiratory insufficiency, nephron reduction. Actually, there's a typo there. It's a liver don't have nephron. Okay, sorry. So structural instability, reduced muscle mass, and malnutrition. So understanding physiological changes will shape pragmatic approach on case-to-case basis. You just have to understand. There's no way I can fit into 15 minutes talk. Okay, so you have to go to like and subscribe my video. So PKPD changes in elderly also have been discovered almost to a full extent. So we know now, like Dr. Mariam said, they have increased sensitivity to anesthetic drug, reduced receptor number, increased receptor sensitivity, and so on. Okay, so all this data. But what is the update? The update now, we now know that physiological and pharmacological changes doesn't really tally with chronological age. Okay, so some patient at 70 years old or 90 years old can still be Prime Minister of Malaysia. Okay, some 60 years old barely able to walk in the grocery stores and so on. So now we now know it doesn't really tally with the chronological age. So age is still just a number. Okay, so we need to assess elderly patient on an individual basis. So because I'm doing research on elderly population, so I went last year to a national conference on aging. I bet many of you didn't know this conference exists. So in Malaysia, we have Institute of Aging, my Aging Institute in UPM. So this, when I went there, I want to know the better insight. What elderly people wants, what are their goals, what do they want? Okay, the recurrent theme involved is preservation of daily function, labor participation, and quality of life. They really want a quality of life, and they want to work. They want to be participate in labor. So the first update is the primary goal in anesthesia delivery and elderly patient should be not just survival. So when we anesthetize patient, we thought, oh, survive enough lah, cukup. All right, just survive. But they actually, if you ask them, they actually want a quality of life. So the primary goal should be optimal quality of life after surgical procedure. Okay, so if you see a lot of QR codes in my slide, that's all the reference. You can take picture and then you can go through the reference, all the interesting references. Okay, so first, when I look back, when I found this research, it's actually quite a huge research. So they do a retrospective registry study. So up to 25% in elderly population will have complication. Will have complication. Up to 25%, very high. One out of four will have complication. All right. So when they look among elderly population, what are the factors that may contribute to complication? Okay, so as usual, as you all know, anesthesiologists, you are all specialized and graduated, so you know all whatever predict complication in the young adult and the adult will be the same for elderly. But in elderly specifically, frailty, ADL, cognitive function is the predictor. One of the main thing is frailty. I think Dr. Mariam already said just now. So in addition to assessment of functional capacity like MATS and so on, DASI and so on, we need to assess frailty in elderly patients. So the first frailty publication was by Fried Frailty Index, the QR code on the other side. So there's a 5 category, you need 3 out of 5. And then, but the most widely used in anesthesia is Edmonton Frailty Scale. Okay, so this is have the most predictive capability to predict functional outcome. I mean, the outcome for the patient. And you also can download the apps to assess the patient. And the Rockwood Frailty Scale, like Dr. Mariam said, is the easiest one. You can administer yourself, very easy. But the having the most predictive power is Edmonton Frailty Scale. Okay, so why frailty is important? It's important because they have, if patient is frail, the elderly is frail, it's considered more of a biological age, the frailty. Okay, so they have odds ratio 2.6 times higher to develop post-operative complication, less likely to be discharged home, increased mortality, increased use of long-term care facility. And if you add the frailty into ASA, it's actually have a much higher predictive power of post-op complication. So frail patients also have increased length of stay, post-op mobility, and financial burden to the hospital. So frail in elderly actually is a modifiable risk factor. How do you modify? So some factors you can't modify. It is what it is. But frailty actually you can modify. For elective surgery, we need to start doing prehabilitation. Many times ERAS ERAS proponent already said prehabilitation is the way to go. So prehabilitation, you increase the functional status prior to surgery. When they undergo surgery, when they recover, they can recover back to 100% or more, right? So prehabilitation involve a triad of physio and occupational therapy, nutrition, cognitive and behavior therapy. For emergency surgery, you need to do risk reduction strategy. You can't be asking the patient to do, oh, you go prehab first. Don't do, we cancel. But no, you need to do risk reduction strategy. A lot of risk reduction strategy have been mentioned by Dr. Mariam as well. Drug dose adjustment, shorter anesthesia duration, choice of anesthesia technique, EEG guided general anesthesia, temperature control, and so on. Okay, so regarding prehabilitation, how do you do it? Okay, you can go to my YouTube channel and then you can watch the prehabilitation in for anesthesia. Okay, so next, one of the main thing in anesthesia, geriatric anesthesia is post-op delirium and post-op cognitive dysfunction. So this review paper encapsulate the important parts for geriatric anesthesiology, where the strength of evidence shows that advanced age, lower educational status, previous stroke, and POCD and also discharge will be the predictive, is predictive of post-operative cognitive dysfunction. Okay, so but elderly is the mostly at risk for cosmetic cognitive dysfunction. POCD is very, because we as anesthetists we don't really see it, but they really suffer. Okay, they have nightmares, they have delusion, hallucination, they can't sleep well at night, their memory power reducing, they can't function. So this is very bad on them. So this is our job as anesthesiologists to reduce this POCD. So next one, regarding POCD and regarding other outcomes for elderly. So are you on the Tiva side or volatile anesthetic side? Are you the gas or the propofol side? Okay, so for elderly, actually it doesn't matter. After years and years and decades of study, actually it doesn't matter. What matter is now we know the update for you is the depth of anesthesia. Okay, in addition to that, there's a long-term survival study. But at one point of time, propofol has been touted as the can improve mortality in cancer surgery, reduce recurrence. In this long-term study, more than 10 years follow-up of the Tiva versus volatile agent, actually doesn't matter. The same. No increase, improve recurrence or mortality. Okay, all right. So why I said depth anesthesia is matters because when this Cochrane library review came out, the optimized anesthesia they suggest that whatever you use, Tiva or volatile agent, if you use correctly at the correct anesthesia depth, it will reduce post-op delirium and it will also reduce post-op cognitive dysfunction. So in this, at the end December 2022 last year, so this paper just came out, published a systematic review and meta-analysis, 15 studies pooled involving 5,000 plus patients. So let's look at high BIS value, 45 to 60 versus 30 to 40. So it favor reduction of post-op delirium and post-op cognitive dysfunction at 3 months. Okay, so you can see that it doesn't matter Tiva or volatile, but you have to use BIS or EEG in EEG targeted anesthesia. Okay, if you use gas, huh? You use MAC already, right? But the MAC is in such an old index, and it's not really tally to the elderly because they have those physiological changes. Next, we talk about effects of dexmedetomidine. It's a promising one. So dosage of dex using started in the beginning of the op, well until the post-op can reduce incidence of POCD. It also shown to reduce inflammation and better neurocognitive function in the elderly. So as you can see, the forest all towards favor the dexmedetomidine. And then parecoxib has been shown a promising result to reduce POCD as well and reducing interleukin 6 and the protein S100B. Okay, in the future, when you see S100B is one of the protein biomarkers of POCD that is currently being publicly researched. All right, but the parecoxib doesn't have as much evidence and as much study as dexmedetomidine. So maybe we can start try to employ dexamethasone in our practice. So a new promise have been given by Remy Mazolam. So you can see today's conference, I mean this conference have a lot of Remy Mazolam into action. So it's a new novel benzodiazepine. Remy Mazolam versus Propofol. This RCT is been done has been done in 400 patients. Propofol versus Remy Mazolam for endoscopy in elderly. So the elderly patient is 65 to not 8 years old, sorry. 65 to 85 years old. Primary outcome is hypotension, less than 30% from baseline. So as you can see, uh, the time to onset of sedation is the same. Propofol and remibrutinib is about 2 minutes, and then recovery also the same, about 9 minutes. When you do, but the procedure is very short. If you look at the mean average of the duration is 10 minutes. So a very short procedure. Actually, remimazolam is actually way superior than propofol because they have the addition of the ester chain at the midazolam structure is enable breakdown of the molecule is easily. So they have a very about 3 times lower rates of hypotension, bradycardia, and respiratory suppression, and versus propofol. So this is for the upper gastrointestinal endoscopic procedure. Okay, next GA versus RA. So which camp are you? So back in 2018 Cochrane review, so a lot of promising result, and a lot of the people in regional anesthesia camp. Oh, okay, so RA is superior. So, but then now GA versus RA, again, it doesn't matter. After years and decades of research, it doesn't matter. What matter is doing it correctly for the correct elderly patient with the correct technique. Okay, if you use GA and you blast propofol 300 milligrams 2 vial, of course patient will die. If you give if you do RA incorrectly, inappropriately, a patient will also die because physiological changes for RA also affect your RA. Okay, because they have shorter Schwann cell, the sensitivity increase. Again, I already talked this a lot in the YouTube recording. Okay, all right. So recently, early this year, February 2023, so the systematic review came up that says no significant difference in terms of safety between RA and GA, post-op delirium, post-op cognitive dysfunction, mortality, and other important safety outcome. Okay, but this huge systematic review and meta-analysis shows that RA can be a promising technique for intraoperative blood loss, reduce intraoperative blood loss, reduce length of stays, and reduce duration of surgery. Okay, okay, so this article by Mahender. So this is a very good article. You can go and have a look. Recent advances in geriatric anesthesia. So where they say in accordance to other society, and one of the best one is Italian society recommendation. So one of the important findings from the review article is that we need to use time up and go. Time up and go means you ask the patient to sit down, start the timing, ask the patient to walk for 3 meters, whether they can finish in, was it 20 seconds, more than 20 seconds or not. So this is a very good, have a good predictive power to indicate patient is frail or not. So if patient is cannot complete with more than 20 seconds, you can try after this when you go out of the hall, so you can know whether you're frail or not. You need to do comprehensive geriatric assessment. Okay, so highly likely to be frail. Okay, so this is one of the first and highest recommendation in the prime Italian society recommendation for the anesthesia, directed anesthesia. So it's a summary, a simplified approach to incorporate new updates. Okay, so now we are being updated. Understand physiological changes to shape pragmatic approach on case-to-case basis. This is, I cannot emphasize this more than enough. All right, so ensure all comorbidities well optimized as per user practices. So you will see all the lines every time when you read. So you need to screen for frailty. Start with time up and go more than 20 seconds, and then on monotone frailty scale if you find you cannot finish it. And then confirm the frail patient or the patient is more than 80 years old, poor maths, and then you need to do prehabilitation and you need to do comprehensive geriatric assessment, CGA, and involve geriatrician if needed. GA versus regional, it doesn't matter as long as correctly performed. So, but for all elderly patient, but even more for this frail patient and those at risk of post delirium and POCD, you need to optimize the work process. You need to have a skillful surgeon. After all, a good surgeon will have anesthesia complications correlates a lot with a skillful surgeon, and because they will have shorter GA duration and lesser risk. So TIVA versus volatile, it doesn't matter as long as you process EEG guidance like this. Use of this 50 to 60 in many in many society recommendation to guide an anesthesia depth for both IV or volatile. So opioid free or sparing anesthesia wherever possible. Use desmetanomidine perioperatively. You can start to try using it, and maybe if not contraindicated, you can try and use paracoxib. But however, the strength of evidence is not that there yet. Okay, so that's all. Your update has been completed. So maybe I hope we can go towards from my elderly ICU research project to my elderly anesthesia project. If many of you are interested to do this research, so that's you can contact me in the email, Twitter, X, or YouTube. Thank you.
To psychological, cognitive, social, and even spiritual aspects